Good evening, everyone. Welcome to the NYU Orthopedic webinar series. We'll be talking about glenohumeral instability today. We have an impressive lineup of speakers who are going to give presentations and case presentations. We'll kick off with Dr. DeBernardis, who's going to talk about the natural history, diagnosis, and evaluation of glenohumeral instability. This will be followed by a talk by Dr. Yao on surgical treatment of glenohumeral instability. And it'll be followed by a case presentation by Dr. Rakito, a case presentation by myself, and a talk on instability with bone loss by myself, and finally, a case presentation by Dr. Kwan. Without further ado, I invite Dr. DeBernardis to take over. Thank you.
Thanks, Dr. Berg. So I will go ahead and get started. We'll do a brief review of the natural history, the diagnosis, and the standard evaluation techniques for patients with glenohumeral instability. No disclosures relevant to this talk. And so there are several variations of glenohumeral instability. It's typically classified by the direction of instability of the humeral head and by the mechanism of injury, whether it's traumatic, atraumatic, hypertonic contraction of the shoulder, such as in a seizure, or just baseline laxity seen in patients with MDI. But for today's talk, we'll be focused primarily on traumatic anterior instability, which is the most common variation of instability in the shoulder. And so, of course, being that it's due to traumatic event or injury, it typically occurs following some degree of high-energy collision, such as in contact athletes, or after a high-energy fall with an anteriorly directed force on the humerus, with the shoulder in the abducted and externally rotated position. And in the upcoming slides, we'll review some anatomy that helps to explain why the humeral head typically dislocates in the anterior direction with the arm in this position. It's much more common in men, with an incidence of about 3 to 1 compared to women. And the overall incidence in the general population is about 23 per 100,000 people per year. But you can see this incidence nearly triples in patients under the age of 20, which is a proven risk factor for recurrent dislocation. And so the shoulder has very little bony constraint due to the shallow nature of the glenoid, and this is primarily the reason for its great degree of arc of range of motion. You can see in comparison to the hip, which has a relatively deep socket to provide stabilization and covers about 50% of the femoral head. The glenoid depth is only about 3.5 millimeters, and so very little of the humeral head is actually covered by the bony restraint of the socket or the glenoid. And so while this is the reason for the natural or the native relative instability of the shoulder joint, it's also the reason why it has such a great degree of range of motion before bony impingement. Additionally, it's important to note that there's a difference or a mismatch in the radius of curvature between the humeral head, which has a radius of curvature about 2.3 millimeters less than that of the glenoid, meaning that the glenoid is somewhat more straight or less round compared to the more curved humeral head. And that's the reason why the humeral head doesn't just rotate against the glenoid, but it also translates or slide in all directions. And so because of this degree of native instability of the shoulder relies primarily on its soft tissue constraints to provide stability. Some of the primary static stabilizers are the labrum, which acts to nearly double the depth of the glenoid by another 2.5 to 5 millimeters, and also creates a relatively negative pressure environment between the humeral head and the glenoid to provide stability. It's also the attachment site of the glenohumeral ligaments, which are additional static stabilizers of the shoulder. And unlike the knee, whose collateral ligaments are isometric, these ligaments are non-isometric, meaning that throughout the majority of functional range of motion of the shoulder, these ligaments are actually quite lax. And so the shoulder also relies on its dynamic stabilizers, that being primarily the rotator cuff musculature. And each of them has a different vector of pull, but when you find the sum of these vectors, it creates a net joint reactive force. And this net joint reactive force is typically along the length of the scapula or perpendicular to the face of the glenoid. And depending upon the position of the humeral head, as long as that net joint reactive force is pointing at the face or the track of the glenoid, the humeral head remains relatively stable. You can imagine as the shoulder is brought into the extremes of range of motion, that vector may point off the face of the glenoid, which typically would result in an anterior humeral head dislocation. However, the static stabilizers like the glenohumeral ligaments act as a check rein, meaning they keep the shoulder within a stable functional range of motion so that the net force is never pointing off the face of the glenoid, and it prevents those extremes of range of motion. And so, as I mentioned before, anterior instability typically occurs in the abducted and externally rotated position with horizontal extension, because this is the position in which the anterior inferior capsule and labrum are typically tensioned to prevent dislocation and keep the humeral head stable. And so if that anteriorly directed force exceeds the resistant force of these structures, then these structures such as the labrum and the inferior glenohumeral ligaments are disrupted. And this also disrupts the negative pressure environment between the humeral head and the glenoid, allowing for an anterior dislocation. This is also the reason why, even after the shoulder is concentrically reduced, there's still an elevated risk for dislocation due to the disruption of this negative pressure environment and the loss of tension of the anterior structures. So there's several different variations of pathoanatomy that can occur in the shoulder after dislocation. We already discussed one of the most common variants being the anterior-inferior labral tear or the Bankart lesion. It may also involve a portion of the anterior glenoid bone, either due to an avulsion or a frank fracture by impaction of the humeral head. And this can shorten the glenoid tract or the face of the glenoid, which increases the risk of recurrent dislocation. There's also different variations of labral injury, including the Glad, Alpsa, and Perthes lesions. And these are just different variations in which the labral injury is also associated with either a disruption of the anterior glenoid periosteum or the anterior articular cartilage. And this can affect potentially the patient's outcome or even surgical management. It's important to look for what's called a Hagel lesion or humeral avulsion of the glenohumeral ligament. And this is an injury in which the soft tissues are disrupted on the humeral side along the anterior inferior glenohumeral ligament. And finally, a Hill-Sachs lesion, which is a posterior superior impaction fracture of the humeral head when it abuts against the anterior glenoid during a dislocation. And this is relatively common, found in about 50% of primary dislocations and approaching 100% of patients with recurrent instability. And this can occur in varying sizes in the superior to inferior and the anterior to posterior direction. And so in evaluating patients, it's important to take a good detailed history. Of course, obviously, these patients will typically present with a history of trauma. They may even have described presenting to an emergency room requiring closed reduction. If you have a patient who has a history of instability that maybe was treated non-operatively and they attempt to get back to activities, they may report recurrent subluxation or shifting events and even pain when they try to get back to high energy activities such as contact sports or even overhead resisted activities such as weightlifting. It's important to obtain a good history because it's important to gauge the patient's relative risk of recurrent instability. So gauging whether the patient has a history of laxity or hypermobility, understanding if they have a history of dislocations of other joints, such as their kneecaps or their patellofemoral joint, the number of instability events in the shoulder and the mechanisms of these injuries, as additional instability events often happen with less severe trauma, and whether they participate in an activity or a sport or even an occupation that puts them at increased risk for recurrent dislocation. And finally, if you're taking care of an athlete with these injuries, it's important to understand not just what sport they play, but at what point in the season they are, because an athlete in the middle of their season may be treated differently than an athlete whose season has ended. And when examining these patients, it's also really important to understand the proximity of the neurovascular structures. The brachial plexus and the axillary artery are immediately adjacent, just in front of the glenohumeral joint. And while neurologic injury can occur, brachial plexopathy is a possibility. The most common variation of neurologic injury by far is an axillary nerve neuropraxia or a stretch injury, which can occur in about 42% of patients. And it might result in patients who complain of sensory disturbance over the lateral deltoid. Depending on the chronicity, it may result in either weakness or even atrophy of the deltoids. It's important to pick this up on exam. Vascular injury is a little bit less common, occurring in about 2% of closed dislocations, and it's a lot more common or has a higher prevalence in older patients. They typically have stiffer, more sclerotic vessels, but you still have to have a high index of suspicion, even in young patients, especially after a high energy injury. So there are several different examination techniques you can perform to assess a patient's degree of laxity or severity of their dislocation, and even understand the direction in which their shoulder dislocated, whether that's the apprehension relocation test with the patient supine and the position of instability of the shoulder to determine if they have an apprehension or concern for dislocation that's resolved with posteriorly directed force, and the sulcus sign, which looks for increased inferior laxity with the arm in the neutral in the externally rotated position. You can also perform a load and shift or an anterior drawer test to assess the degree of anterior laxity. To get a good history of hyperlaxity, you can use what's called the Baten's criteria, which is a summary of different variations of testing of the joints of the hand, as well as the elbows and the knees, to determine the patient's baseline hypermobility. The difficulty with this criteria is that it has a relatively high false positive rate in the glenohumeral joint, since it already has a relatively high degree of laxity and motion, even in a normal patient. And it's kind of a moving target because the number of points required to have a positive score changes with age. It actually decreases over time with age, as you can expect a younger patient to be much more lax than a patient, say, over the age of 40 or 50 years old. And finally, it's important to do a thorough rotator cuff exam, as rotator cuff tears can occur with glenohumeral dislocation. So when imaging these patients, we start with a good set of radiographs in multiple different planes. It's required to assess the injury. Standard views, including AP, Grashy, scapular Y, and especially an X-ray view, are important. The X-ray view can help to both confirm the direction of the dislocation at the time of injury, as well as confirm concentric reduction. It's not uncommon that persistent dislocation is missed, especially on a Grashy view, and this is even more common in posterior instability. And the additional X-ray views can help to evaluate any additional bony injury. So on a standard Grashy view, you can look at the anterior glenoid cortical line, In the picture on the top, you can see this should be a hyperdense white line. You can see this along the superior half of the glenoid, whereas it gets much less dense on the inferior half, and you can see in the axillary pouch is a free-floating bony fragment representing a Bankart fracture. It also helps to assess a Hill-Sachs injury or the presence of a greater tuberosity fracture or even a coracoid fracture that can happen with anterior instability. An MRI is probably the most sensitive modality for evaluating soft tissue injury, both its presence and classifying its type. It can help differentiate between a standard anterior labral tear seen on the superior left image versus one of the variations such as the ALPSA lesion or the anterior labral periosteal sleeve avulsion seen in the top right photo. It's also important to rule out additional labral injuries in about 22% of patients, the injury may not be confined to the anterior inferior labrum, but may rotate around the superior aspect to involve the superior labrum, resulting in an associated slap tear. And a coronal view can help rule out the presence of a Hagel lesion in which you see either intra-articular contrast or intra-articular hematoma present through the axillary pouch and into the inferior musculature. And this is often missed or underreported, even though it's reported with an incidence of about 7.5 to 9%. The incidence of this is likely higher as it's typically missed. An MRI is also useful, of course, for ruling out a rotator cuff tear, as this is much more common in patients over the age of 40. There are several studies that show at least a third of patients present with either a rotator cuff tear or a greater tuberosity fracture. And another study from 2009 in the lower portion of this slide, looking at all patients presenting to a level 1 trauma center with glenohumeral instability, found an overall incidence of about 54% of rotator cuff tear, and this incidence substantially increased with increasing age. Finally, it's somewhat debated whether MRI is an appropriate modality to measure bone loss of the glenoid, with many review studies in the literature suggesting a similar accuracy between MRI and CT scan in measuring glenoid bone loss along the anterior aspect. And additionally, you consider using an arthrogram, which is injected intra-articular dye, to identify a labral tear that may be missed. However, if an MRI is obtained shortly after an acute dislocation, often the intra-articular hematoma or the hemarthrosis can act almost like a dye to increase the sensitivity. CT scan is important to consider even potentially in a first-time dislocator, as there are several prospective studies, including this one, that found an average of 7% bone loss even in a patient's first dislocation, which can nearly triple to about 23% after recurrent dislocation. And this is the basis for considering surgical management even in the first-time dislocator. And while the glenoid can help to measure bone loss, it also helps to characterize it, whether that's acute bone loss, such as an acute fracture of the glenoid, versus attritional chronic bone loss due to several dislocations over a short period of time, in which you don't find necessarily a large fragment, but actually a change in the contour of the anterior glenoid cortical rim. There are several different reported methods of measuring anterior glenoid bone loss, typically utilizing the inferior best fit circle or the inferior diameter of the glenoid. And there are some studies that suggest that maybe a more volumetric or surface area based analysis might be more useful than a simple linear or direct measurement of the inferior glenoid. However, like most things in orthopedics, when there are several ways to do something, it means we probably don't agree on a single way that is best, as a number of review studies have actually found that none of these are necessarily more accurate or more reproducible than any of the other methods described. And finally, a CT scan can also be useful for looking at the humeral side of the injury, especially characterizing the Hill-Sachs lesion. You can measure the glenoid tract, and you can superimpose it over the length of the Hill-Sachs interval to determine if this is a on-track or non-engaging lesion, or at least the chance of this occurring. And you can see how that changes if you have anterior glenoid bone loss, as when the glenoid tract shortens and is superimposed over a Hill-Sachs interval, you can find that it now lays on the interval. And this is depicted in this three-dimensional image showing that for a given Hill-Sachs interval or Hill-Sachs lesion, it can convert an on-track or non-engaging lesion into an off-track or engaging lesion just with increasing glenoid bone loss and decreasing the glenoid tract. And so when evaluating these patients, one of the most important things you can obtain from them is any risk factors for recurrent instability, such as those listed here, whether that's age less than 20, if they participate in a contact or overhead competitive sport, male sex, history of hyperlaxity, both the presence and severity of glenoid bone loss, and the Hill-Sachs lesion size, as these have all been proven to increase patients' risk for dislocation and can help to dictate management. Thank you.
Thank you, Dr. DeBernardis. Quick question. We have 2 minutes for questions. So when you talk to a patient who's a first-time dislocator, how much does age and presence of bone loss kind of factor in your discussion with the patient for recurrence?
Sure. I think it's incredibly important because to me, age is just a surrogate for activity level. So the same patient, a patient who has maybe 10 or 15% anterior glenoid bone loss, who is 45, works a desk job and just likes to lift weights lightly at the gym to stay in shape, has a much different risk than a patient who's 19, plays lacrosse, and with the same degree of anterior glenoid bone loss. I think that patient has a much higher risk of recurrent instability. And so I think that risk is much more important to take into account when determining treatment. And I'm more likely probably to offer that young patient surgery due to their demand they have on the shoulder.
Another question, CT versus MRI. Oftentimes we get asked that question, hey, what would you want in a first-time dislocator, an MRI or a CT scan as an advanced imaging? Are there certain guidelines that you follow, or you are a CT scanner for all or an MRI scanner for all?
So this may be controversial, but if I have a patient who I'm considering non-operative treatments, their X-ray, the X-ray is not the most specific or sensitive for glenoid bone loss, but as long as the contour of the glenoid looks normal, their Hill-Sachs is relatively small, and I think they have a relatively low chance of recurrent dislocation, and I tend to treat them non-operatively, I don't even obtain an MRI on a first-time dislocator. If I have someone who I'm considering surgery, even first-time dislocation, if they're a high-contact athlete, then I do move immediately to MRI. I only obtain a CT scan if there's any hint of bone loss either on the X-ray or the MRI.
So you brought up a very good point about rotator cuff tears in elderly patients or patients above the age of 40. Does that change your diagnostic modality? Let's say you're seeing a 50-year-old person, first-time dislocator, and clinical examination can only be so good. Would you go for an MRI in those cases, or you play it by how the case presents?
So I typically go based on their physical exam, and I think there's a difference between a patient who walks into your office 2 days after a dislocation versus what's not really uncommon in my practice, which is someone who walks in maybe 2 weeks after dislocation. Someone 2 days out is going to have severe pain. If you test their rotator cuff, motion in almost any direction is going to hurt. I'm probably more likely to order an MRI in that person because I can't get a clear diagnostic exam of their rotator cuff. Typically, if they're a week or two out, their pain has resolved or has significantly decreased. I feel I can get a more accurate exam on their rotator cuff. If they have good motion, good strength, then I will debate whether I'm going to order an MRI. But if they have any indication, even a little bit of pain with rotator cuff testing, any degree of weakness, difficulty lifting their arm, then absolutely I'm getting an MRI on them, especially if they're over the age of 40.
Thank you very much for a great presentation and question answer session. We'll move on to our next presentation by Dr. Yao on surgical treatment of glenohumeral instability. Dr. Yao, please take it away.
All right, thanks everybody. So I'm Jay Yao. I'm one of the faculty in shoulder and elbow. So my topic is the surgical treatment of instability, particularly arthroscopic Bankart and remplissage. So let me get this working 1 second here. So we'll talk about a couple things. We'll talk about some background information about arthroscopic Bankart repair, some of the surgical techniques that are relevant, as well as some background for remplissage and the surgical technique for remplissage. So let's start with arthroscopic Bankart. So the question is, what is a Bankart repair? And so, what's commonly known as the Bankart lesion was actually first described in 1908 in German by Dr. Perthes. And I think life's a little bit unfair. Perthes got a little bit relegated, but you can see here in these original drawings that, the very classic mechanism of dislocation that Dennis was talking about, where you get this anterior dislocation and damage to the anterior inferior labrum. And what he had proposed at the time was actually repairing kind of in a running stitch fashion using metal staples that went into the glenoid and then running a silk suture and bringing it over. That being said, I think Dr. Bankart gets a lot of credit, 20 years later for really popularizing the Bankart repair, what's commonly called the Bankart repair, for people with dislocated. And these were back in the good old days where you could publish a paper with just 4 patients. And so he brought up a really good point that at the time when people were treating persistent or chronic instability, there were really 2 approaches. One was to try to shrink the capsule, just make everything tighter, or to try to support the capsule. And so people were even doing things such as taking a strip of deltoid and moving that to the inferior glenoid to try to bolster the shoulder up. And I think Dr. Bankart in his paper, if you go read it, makes it very clear that this doesn't really make sense, right? What we should be doing is probably thinking about the anatomy of the defect, of the problem, and trying to think about what makes sense from an anatomical standpoint. And so for me, I think I agree with this. If you think about a Bankart injury like we have here on the left on MRI, I think in many ways we should think about it the same way we think about like an ankle fracture. We have an anatomical problem. How can we restore the anatomy? And so this is not a fracture talk, but I will say that some of the principles of fracture care that we're all very familiar with still apply to soft tissue. And one of those is the importance of anatomical relationships. And so Just, the AO says, you have to restore form in order to restore function. And that's certainly the case with labrums too. And so in general, if you really think about from a bird's eye view, what is a Bankart repair? What are we trying to do? We're trying to restore the anatomy so that we can restore the function. And so when it comes to the shoulder joint, we're always talking about the tug of war between stability and motion. And, there's things you can do to make someone super stable. You could even fuse them, but that's not good for their motion. And so I think what a Bankart repair is trying to do is to straddle that divide and try to give people good motion and good stability. Now, there's a big caveat to this, and it's not always possible to restore the anatomy. We know that with continued dislocations, there's changes on a gene regulation standpoint, gene expression standpoint, to the structure of the labrum. And we know that labrum, after multiple dislocations in particular, is not the same labrum that patient was born with. There's a second big caveat, which is it's actually really hard from a technical standpoint. I think a Bankart repair sounds easy in a lot of ways, but if you really are very precise and very meticulous about how you do it, it's actually really hard to restore the anatomy perfectly. It's easy to overdo it or underdo it. And for that reason, I think a lot of times when we talk about a Bankart repair, or when people write about a Bankart repair, we're not just talking about restoring the anatomy, we're doing that and something else, right? And so you'll see Bankarts done with a capsular shift, right? That's erring more towards stability. A remplissage to try to, we'll talk about that later, but essentially, a lot of times we're doing a little bit more than a Bankart because we'd rather err towards stability. And so, again, if we're trying to restore the anatomy, these Bankarts were originally done open. And so you have to go through the subscapularis somehow. So originally described splitting the subscapularis and working through the muscle. But either way, you can now reflect the subscap if you do an open Bankart. But the key is to really identify the defect and bring back labrum and usually some capsule with it. Because like I said, we're erring towards stability, and then we're paring that back down to the gleno to recreate the bumper and the concavity of the shoulder. Obviously, we're not doing that many open Bankarts. We all know this. Arthroscopic Bankart has become really the standard of care, I think, if you're going to do a Bankart. And there's a couple of different reasons for that. Now, who should get a Bankart? I think this is actually really nuanced. And, there's no absolute indication for a Bankart repair. I have a very hard time telling patients, like, you have to have this done. It really is relative. And I think some of the people where I might kind of guide the discussion in that direction is the first-time dislocator who's a very athletic patient who's going to be putting their shoulder to the very limits of stability. Same thing with high-demand athletes. Patients who've already failed non-operative treatment, who've had recurrent dislocations. Like I said, we know that labral tissue changes. So if somebody comes in with 5-10 dislocations, we know that they've kind of proven that they're not going to do well without surgery. How much bone loss can be tolerated, I think, is a bit of a debate. And I think Dr. Verk's going to talk about that in his bone loss talk. And then it's kind of similarly, we're talking about on track, off track. There's still a role, I think, for with Bankart if it's combined with a remplissage in the right patient. So why do these arthroscopically? I think we're used to doing these arthroscopically. I think most of us who've trained more recently, there's improved visibility with doing it arthroscopically. You might have better precision because you're, under a magnifying glass. In some ways, it's a bit of an easier recovery, small incision, which means a faster return to sport. I think the big reason in my mind, though, when I'm talking to patients is that you don't violate the subscap. You're working above the subscap through the rotator interval, typically. Decreased surgical time, decreased blood loss, decreased length of stay. And, I think there's less violation of some of the proprioceptive fibers that go into the labrum when you do this arthroscopically. But there are some caveats. If you look at the outcomes, there have been higher rates of redislocation historically with arthroscopic Bankart. And so for a while, people were saying, well, maybe, open Bankart's a much better surgery. I will also say, like any new surgical technique, if you look at the early data versus data that's more recent, there is, from a professional standpoint, I think as a field, we've gotten better at doing arthroscopic Bankart. So when I look at the data, I don't think that there's a big difference in the primary Bankart repair between doing it arthroscopically and doing it open. I will say, like, the people that do it open say that they get a much more aggressive capsular shift, and that's certainly, I could see how that'd be the case, but I still believe arthroscopic Bankart is the way to go. So how do these patients do? So this is, again, it really depends, right? Like anything, when you're talking on a research perspective, you can take a really big view, but when you're talking about an individual patient, what do they care about? And it really, really depends. And so this is a good systematic review out of Duke showing essentially that arthroscopic Bankart repairs, they do really well until they don't, meaning that their functional outcomes are really good, but they have a high-ish rate of dislocation. So if you look at what they found in their meta-analysis, they have a pretty good return to play rate, about 75%. Their constant scores are pretty decent, and patients are pretty well satisfied. But there are some recurrences, and in fact, when you pool all this data, which includes that early data, where maybe we weren't as good at doing these, you can see recurrences up to 30%, and we know that whether instability surgery alters arthritis, I think, is a bit controversial, much like the ACL and the knee. I want to be completely transparent with my patients and say, look, like some people argue that by making you more stable, I'm going to prevent your arthritis. But even with an arthroscopic Bankart, a lot of patients are going to get some arthritic changes even at 10 years. If you look at data out of Europe, so Christian Gerber's group published in JBJS a comparison of arthroscopic Bankart repair for open Latarjet for initial surgery for anterior instability. And you can see here, if you look at the Kaplan-Meier curves, Bankart's in red. In every time, or in every way that you would think about instability, whether it's redislocation here in the top left, reoperation here in the top right, or instability on exam or ultrasound, there is a decay that happens with Bankarts over time. And so some people say, well, Bankarts will fail. It's just a matter of time. I still believe in this data, and I think that one of the reasons that it's really important when you're talking to patients to not just blindly take this data is because there's a lot of factors that go into how somebody does. And I think it depends on these things. It depends on the quality of surgery, which is what we can control, the quality of tissue, and the quality of the patient. And so how good of a labral, just like doing fracture surgery, just like fixing a plateau, just like fixing an articular fracture, how good of a reduction you get, how well you mobilize the labrum, and how well you fix it matter. And so we know that 3 anchors, probably 4 or more, is actually the best way to do this if possible. You want to really make sure that your labrum is mobilized, that you have an appropriate level of tension, that you've done a good technical surgery. The quality of tissue matters, right? And so this is the argument to get to these sooner. If somebody keeps dislocating, then we know that is going to stretch out that tissue and make it not as healthy. When we're passing, instruments around the labrum to pass suture, we've all been in circumstances where maybe, someone's struggling and they keep just tearing up the labrum. That's obviously not good. And then whether somebody has an underlying collagen problem probably matters too. And then the patient matters as well, right? How do they rehab this? What are their expectations and what are their goals? So let's talk about just very briefly the technique. So there's lots of ways to do a Bankart. There's not one right way, but you really want to set yourself up for success. So I do these in the lateral position because I like to have some distraction across the joint. I think this is the best way to get it. If you do a beach chair, you have to have somebody pulling a lot of times on the arm. Your portals really matter. You want good portal spread, especially if you're doing, I think what most people do now, which is viewing from the back, or you can view from the front, but having 2 anterior portals. You want to make sure that you really mobilize the labrum and that you prepare the bone in such a way that you can get the labrum to grow back. You don't want to remove bone. You just want to decorticate it a little bit, just dust it up a little bit, but you don't want to remove bone. Once you pass your sutures, you want to make sure you get an anatomic reduction in the number of anchors matter. So here are just some surgical pearls. You want to make sure you do a really good diagnostic. Don't miss a labral tear that's bigger than you realize. Make sure that your anterior portals are not fighting each other so that you don't keep banging up against yourself. Mobilize the labrum. If you can get it to float up, that's a really good sign. Prepare the glenoid rim. Don't take too much bone, but take enough tissue. It's better to have too much tissue than not enough. I do believe this because you don't want this patient to redislocate, but you don't want to grab the axillary nerve. I've seen that once in training, and that's a really horrible complication. And then the anchors have to go in the right place, and you need enough of them. Okay, so I think at least 3, if not 4, and then don't. 6 o'clock is always, I think, a little more posterior than you think when you're viewing from posterior in particular. So let's talk about remplissage. So again, what is remplissage? We all know that it's described by Wolf. And it really, again, I don't want to impede on Dr. Verk's bone loss talk, but very briefly, when patients dislocate, they tend to get a Hill-Sachs, and that Hill-Sachs can engage and cause instability. And so the remplissage is, as you see here on the left, the anchor pulling the infraspinatus and capsule into the cuff to try to fill that defect, to convert that defect to be extra articular. I think remplissage is still controversial. I know some people believe it's going to fix everything, but who gets this? In my mind, somebody who's off track, and I think Dennis already talked about, and Dr. Ver's going to talk about on track, off track with bone loss. So I won't belabor that point. Some people say in the contact athlete, we should really be doing these a lot more. I'll skip this because I want to leave that for Dr. Verk. But in general, we all know this formula. What you're looking for is 83% of the glenoid, and then you subtract any glenoid bone loss, and then see if that's how that correlates or how that relates to the humeral head defect. Again, I think with contact athletes, some people say that we should be doing these more routinely for them, and some people have even proposed doing these in everybody to really try to get everybody stable. I'm not there yet personally. I think there are some downsides. So if you look at pooled data, there's probably a little bit of loss of external rotation, about 10 degrees. And then we don't know what happens to the cuff health. There's a study out of Kaiser showing a 13% reoperation rate in patients with remplissage. And that was mostly driven by debridement and subacromial decompression. So you wonder if maybe there's some cuff irritation when we're jamming these anchors through the rotator cuff. So really quickly, surgical technique for remplissage. The nice thing about remplissage is it's easy. So what you want to do is you identify your humeral head defect, and you want to put anchors on both ends of the Hill-Sachs so that you're getting a really nice stuffing of the capsule and infraspinatus into that defect. And so here you can see placing one anchor there, and this is a knotless technique, and you can pass one anchor into the other and sucking that down. Some surgical pros. I think even if you don't think it's a big deal to do this as a cuff, you might as well be gentle with it. I think you're going to use a spinal needle for an accessory remplissage portal, and then try to use a small switching stick. Try to be very gentle when you're passing through that rotator cuff and capsule. And then again, anchor placement matters. So the more medial anchors may have a greater effect on reducing external rotation. I think the insertion angle and spread to match the Hill-Sachs is really important. So these are the things that we talked about. I'll just end it here, and I think Dr. Rakito has a case example for this.
Thank you, Dr. Yao. That was very comprehensive. I think for a minute, can you talk about what your indications are for arthroscopic Bankart repair in a first-time dislocator?
Yeah, so for me, I have these are visits where, like, when I know they're coming back, I try to block out 30 minutes because it's a really hard conversation if they've only dislocated once. I personally err a little bit towards non-operative management, and I think that's because a lot of the patients I see are not necessarily professional athletes, right? They're weekend warriors, but they tend to be young, which means rehabbing from a surgery is a big deal to them. It's a really big deal to take that much time off from what they love doing and to be immobilized to protect their labral repair. So I typically take them through the evidence as I know it, the risk of arthritis, the risk of instability. And I will say 9 times out of 10, they choose non-operative management, and they say, you know what, I want to prove it. What I do tell them is, if you dislocate again, then we really do need to talk about surgery. But I think 2 dislocations is okay. I know some people disagree with that, but so far, I haven't been too badly burned. And I think a lot of these patients are really happy that they were able to avoid a surgery, able to get back to rock climbing, sports without needing to go through, what ends up being 6 to 9 months of recovery.
Thank you. Dr. Rakito is going to be presenting the next case.
Can everybody hear me? Great. Good evening, everyone. Welcome to our webinar. I've been asked to present a case of a patient undergoing an arthroscopic Bankart repair, and this is the case of a contact athlete. So I'm going to run you through this case, and we'll pause throughout to give you some insight. So this is a 17-year-old right-hand dominant male high school senior. He is a 2-sport contact athlete. He plays lacrosse and football. And he presented to us with left shoulder pain and instability for 7 months duration. He sustained a left shoulder dislocation during a lacrosse game back in the spring. He was reduced on the field by the team physician, underwent a brief course of physical therapy. He sat out for the rest of that lacrosse season, but being a football player as well, he returned to football during the late summer, early fall, and unfortunately continued to experience episodes of instability during preseason practices and then the early part of the football season. So it's now football season, and he's presenting with left shoulder pain and instability. His physical examination showed pretty near full range of motion. He had a positive apprehension sign at 90 degrees of abduction, positive relocation tests, no sulcus, no signs of generalized ligamentous laxity. He was stable with posterior stress, push-pull, and had normal deltoid rotator cuff strength. X-rays didn't show any bony deficits. However, he came with this study. This is an MR arthrogram, which shows, first of all, there was no Hagel lesion. You can see here on your left in the middle view, you see here a Bankart lesion and really just some flattening of the humeral head. This is not the whole study, but certainly not an engaging Hill-Sachs lesion. And on this sagittal image, you see here the anterior Bankart lesion. He also brought some three-dimensional imaging. Now, I know our previous speakers spoke about indications for getting these various studies, but this particular patient came with these studies. I don't routinely get all of these studies, but in this particular patient, I think it's important to look at the bony anatomy three-dimensionally because of the history that I presented. So with this CT scan with three-dimensional reconstruction, we're using a perfect circle model to verify that there was no significant anterior glenoid bone loss. And again, just some flattening of the posterior humeral head, no real significant Hill-Sachs lesion, at least certainly not an engaging Hill-Sachs lesion. So going on with this case presentation, I'm going to run through this video and stop it along the way. So we begin after we usually do these under a combination of general anesthesia with a interscaling nerve block. I always do an examination under anesthesia. You can see here to get a sense for their instability, not necessarily to refute or change my preoperative decision making, but just to confirm. And I will tell you that you really should not be second thinking your preoperative decision making at this point. So this is really more for confirmation. Like Dr. Gao said, I prefer to do these in the lateral decubitus position. I have used many different distraction devices over the past several decades of doing these. This is what I'm doing these days, using standard lateral traction, 10 pounds of skin traction, and I have started using this hydraulic distraction jack, which is prepped and draped separately, which I'll show you, which really I think allows for excellent distraction of the humeral head away from the glenoid fossa. So I'll kind of put that in ahead of time just to make sure it's in the right location. And then I'll begin scoping from the posterior portal. I've marked out my bony landmarks, chromium AC joint, coracoid process. These are my two anterior portals, as was previously stated. There should be ample distance between these two portals. My anterosuprolateral portal is just off the anterolateral edge of the acromion, which will translate to a very high rotator interval portal. Both of these portals are gaining access through the rotator interval. So this is my anterosuperior portal, just off the acromion. And then I have an anteroinferior portal, lateral and just inferior to the coracoid process. So these really do need to be separated by a good inch and a half, preferably, so you don't have crowding when you're performing the procedure. So here we are scoping the joint. You can really see the injury from the back. You had a glimpse of the Bankart lesion, and now you're looking at the Hill-Sachs lesion. Again, what I would consider a relatively small lesion, and certainly non-engaging. Look at the superior biceps labral anchor complex, the rotator cuff, and now we're turning the arm around. So we've turned the arm, so it's now in line with the patient, probably just about 15 to 30 degrees of abduction. And we're bringing this separately draped hydraulic lift, if you will, this jack in here. We planned out where this goes on the table ahead of time. So it's going to go right underneath the axilla. And then there's a little control lever here that allows me to distract the humeral head. And you'll see in a moment what that does when you have the scope in the joint. So it's fixed in position, and look how it just brings the head away from the joint, giving you what I consider to be really excellent access. Essentially, this frees up your hands, your assistant's hands, and allows you access to really where the pathology is, which is in the anterior-inferior quadrant of the shoulder. You're not struggling with the humeral head. These are our two portals, which you had a glimpse of going across the rotator interval. I put two instrument cannulas there, and then we can start working on the lesion. We'll initially clean up some of the debris. There's a little bit of chondral fraying at the mid-glenoid notch, and you really want to use an elevator here to release the entire capsulolabral complex, and then prepare the bone using a shaver and a rasp. So now I've put the scope directly through the anterosuperior portal, and I'm looking down on the lesion to your right, the native glenoid on your left, and I think it was, I don't remember if it was Dennis or Jay, but I'm sorry, but you really want this tissue to be floating, as they say, so you can put it back as anatomically as you can. You see a little sliver of bone here in the tissue, which is not uncommon, almost like a little periosteal sleeve. Here's the native bone here, and you can see how we've mobilized it. We've stripped it all off the neck, and we've made it ready for repair. So there's that view there. You can see right down. And then I will mark out my anchor placement. I use a radio frequency one because I find that marking these out in advance is helpful, because as you start to repair the labrum and tie your knots, whichever way you're going to fix this, you can lose track of where your previous anchor was. So I like this technique of just using the radio frequency wand to just kind of plan out my placement. So I usually use 4 anchors for most of my repairs. So these anchors are going to be marched up from inferior to superior, 7, 8, 9, 10 o'clock in this left shoulder. Once I've done that, begin antero-inferiorly with my first anchor. This is anchors being put through the antero-inferior portal, which you see there. And I'm actually reducing, I use a grasping device to grasp the tissue and really try to put it where I think it needs to be, or to reducing it just as you would, I think as was mentioned earlier, like you're fixing a fracture. So this is a fish mouth drill guide. These anchors are placed directly onto the anterior glenoid rim, directly onto the articular margin, because that's where this tissue avulsed from. Placing them more medially along the glenoid neck, I think, is a common mistake, unfortunately, and really what you're doing is you're just leaving them with a Bankart lesion, which is what you're trying to repair. So the first anchor is placed at around 7 o'clock. We'll seat the drill guide, place our anchor. I tie knots. I don't have any issue with knotless repairs, but I guess still a knot tying surgeon. Testing to make sure that the anchor is well fixed. And then it's suture management, bringing one limb out through the anterosuperior portal. And then I use a shuttling technique, grabbing the labrum. And I think it's important to say here what you're trying to achieve. So it's not just a east-west repair. It's also a south-north repair. So you're not just repairing it, but I think in many of these people, there is a capsular injury, and tightening the capsule along with the labor repair, I think is important. I don't think I've ever over-tightened somebody. I'm not sure I can do that, but I am obviously aware of the neurovascular structures, particularly the axillary nerve, as was mentioned earlier. But I'm taking up this first one, which is probably the more difficult one to pass, with a angled type of shuttling device, placing it just below the tear site, and then grabbing some capsule as well, with the goal of creating a nice bumper onto the glenoid rim. We tie knots as we go, and then we march up along the glenoid rim, creating a nice speed bump. At the end of the repair, I take a look from the anterosuperior portal, replacing the scope, make sure I have a nice stout labor repair. The head is centered in the glenoid, and I was pretty happy about this. But so that's what we ended up doing, and again, I thought I was pretty happy with this repair. We followed him along, rehabbed him, and eventually cleared him about 6 or 7 months to go back to sports. So he reappeared after pretty close follow-up at about 11 months after his repair. And he had a history of left shoulder pain for the prior 6 weeks. He was playing in a football game and re-injured his shoulder blocking someone. He felt the shoulder slide out and back in. He was put out, to rest for the ensuing 2 weeks, and then unfortunately his shoulder continued to come out of place, to continue to sublux. No frank dislocations, but subluxation episodes and a feeling of instability. He was apprehensive on exam. We didn't get an axillary review because thought that would have not been a good view to get for this particular patient at that point in time. But you can see where our anchor placement was. Head looks fairly centered, at least on this Y view. We did get 3-dimensional imaging, and you can see here now more of a Hill-Sachs lesion has developed. You can see here a recurrent Bankart lesion, probably with some bone here. And you see our prior anchor placement. Now when we do a perfect circle, you see that there is some measurable bone loss that wasn't there before. So what do we do? I guess, what did I miss? What do I do now? I'm not sure. I'm pretty humble, as my colleagues can attest. I'm not sure I missed anything. If you look at the literature, as was previously mentioned, unfortunately, if you look specifically at those studies that have focused on contact collision athletes, you're going to see a substantial recurrent instability rate, probably up to 1/3 or more in some series. So I'm not sure that this was technical. I think that there were patient factors from a contact athlete standpoint, young age, and all the other risk factors that were discussed previously. The question is what to do now. This patient does not want to stop engaging in contact collision sports, and I don't want to rain on anybody's parade who is to follow from this talk, but these days, because of experiences like this, I will put out there, and we can certainly have more discussion with it on the chat, but I have been, maybe not so much for revision cases, but certainly for primary cases, for contact collision athletes, I am, and I know that this is perhaps somewhat controversial, I am almost routinely doing a remplissage on my contact collision athletes who I'm doing arthroscopic primary repairs on. I think that there have been a couple of good randomized prospective studies out of Europe, I think the UK, that have shown good outcomes, actually better outcomes than just doing Bankart repairs alone, lower recurrence rates, and although there is potentially some loss of external rotations was mentioned, I am not finding that to be much of an issue from a patient symptom standpoint. And I think most patients would accept that with the goal of regaining stability. Anyway, I don't want to take up the next speaker's time, so to be continued.
Thank you, Dr. Rakito. That was a great presentation and a follow-up. In essence of time, we'll continue. So good evening again. I'm going to present a case. So 28-year-old left-handed dominant male with recurrent left shoulder instability. His first dislocation was at the age of 27 while wrestling with his friend. Went to the ER to get it reduced. Subsequently had 6 dislocations prior to seeing me, and he was able to self-reduce most of them. Majority of dislocations were with certain degree of trauma. No dislocation in sleep, nothing in past medical or past surgical history. Examination had a fairly good range of motion, good rotator cuff strength. Definitely had a Biden score of 9, like Dr. DeBernard has pointed out too in his talk. Patient had a positive labral shear test and apprehension test with Job's relocation and a negative O'Brien test. Patient brought in the radiographs, AP and a SCAP-Y view, and the radiographs are shown here. Did not see much anterior glenoid bone loss. He also brought in an MRI. The specific cuts on axial, coronal, and sagittal views are shown here, and basically shows some amount of bone loss anteriorly using the perfect circle technique as described by my previous speakers. No Hagel lesion, cuff seems to be intact. And it seems like he has a shallow, broad-based Hill-Sachs lesion based on the glenoid tract measurements, borderline off track. So I'm going to go to treatment options right off the bat here. And this is basically something we tend to see more and more, where the treatment options can fall into just a soft tissue operation like a Bankart repair, which can be done arthroscopic or open. Arthroscopic Bankart repair with remplissage, and then bone block procedures, which include ladder J, use of allograft or autograft, and finally, bone block procedures with remplissage. So for me, this patient was a young male with a dominant shoulder involvement, multiple dislocations prior to presentation, presence of shoulder hyperlaxity, and subcritical bone loss in a superactive patient. So these findings made me pick up an arthroscopic Bankart repair plus remplissage. I felt that the bone loss was not enough for me to jump straight to a Latarjet. And his hyperlaxity, his dominant shoulder involvement, multiple shoulder dislocations kind of steered me away from just an arthroscopic Bankart repair. So in this patient, I did it in a lateral DQ, which is what my preference is for instability. And to begin with, just like Dr. Rukita showed in his video, I start off with a posterior portal in order to gain access into the joint, and then I'll create my standard anterior and anterosuperior portal. If I know that I am doing a remplissage, I will move my scope into the anterosuperior portal so that I'm looking at the Hill-Sachs lesion in the view shown in the far left. I will make an additional posterior portal in order to put my remplissage anchors. I use 2 anchors, and I tend to put them in the center of the Hill-Sachs lesion. It is important, if you are doing a 2-anchor technique and you are only doing single passes through the capsule, that you have a sufficient degree of spread between these 2 anchors in order to have a nice box of capsule and the infraspinatus in order to do a remplissage. We will talk about the sequence of doing the repair, remplissage as a discussion in the next few minutes, but I just wanted to show you what was done for this case. This is what the patient's diagnostic scope looked like from the posterior view, where there's an ALPSA lesion, not much of glenoid bone loss. And basically just based on the principles described by Dr. Rukito and Dr. Yao, 4-anchor repair. I typically do a mattress followed by a simple for my 530 position, and then I do just simple suture anchors up at 430, 330 position. I will use a body anchor at my 530 position, but my other 2 or 3 anchors will be all suture anchors. Once I'm done with the repair, that's when you go in and tie the remplissage sutures in order to finalize the operation. So before I go into a discussion, which is more important for this case, I'm going to quickly run a couple of things for remplissage. Like Dr. Yao mentioned, remplissage means to fill in French. So it is basically a capsulotenodesis. And what are we doing? We are basically taking the posterior capsule and the infraspinatus tendon and filling it into the Hill-Sachs lesion, as shown in these figures to the far right. Now, studies have shown improved joint stiffness and stability and decreased translation with remplissage compared to arthroscopic Bankart repair alone. The way I look at the Bankart repair is that it is an anterior-inferior restraint, a restraint that pushes the humeral head back when it tries to subluxate or dislocate and provide capsular tension or tightness, whereas remplissage is pulling the head from the back, which prevents, again, anterior translation. Eugene Wolf was the first to describe arthroscopic remplissage. And now we're going to go into surgical technique. So Dr. Kwan, I know you kind of like doing instabilities in beach chair position. Is that correct?
I would say I do think that lateral decubitus position is easier for intra-articular work that we're talking with instability. But that being said, I at least for me, because I do a lot of open shoulder stuff as well, it's just difficult in the OR to keep changing positions. And I feel comfortable doing them in the sitting position as well. So I just kind of keep everything in a semi-sitting position.
So do you ever switch based on just remplissage? Do you find remplissage being harder or easier in lateral position versus a beach chair position?
Once again, I think everything is a little easier if you're intra-articular work. So either remplissage and Bankart, I think those are both easier on a lateral decubitus position, just exactly what Dr. Wakito talked about, where your ability to distract is easier. But once again, I feel comfortable doing them in the sitting position. So I am able to do that. And like this main reason is to just kind of keep the OR people happy so that we don't have to keep switching back and forth.
Makes sense. Dr. Rikito, I know you do a lot of these in lateral position, and you probably do more remplissage than any one of us. Any tips or tricks for portal placement?
So I view from the anterosuperior portal, like you said. I have two working portals in the back. With the first portal is more superior. The two posterior portals is just that viewing portal that I first created. That's my standard posterior viewing portal that I think all of us are familiar with. And then I use for that additional portal, I use a spinal needle technique to localize it. And then I actually do put a cannula back there just for the technique that I do. I think it's easier for me to work through it's a small, I think I use a 5.5 cannula back there, which is big enough to house the drill guide, place my anchors. I tie knots, and I know there are knotless ways of doing it, but I tie my knots at the end once, just like was said before. For the remplissage, I do the remplissage, suturing and passage first, repair the Bankart lesion, and then tie them at the end of the case. And I tie knots. They're blind knots, they're arthroscopic knots, but I feel comfortable with that. I know there are folks that find the sutures outside the joint. I just don't think that that's necessary to do. Anchor placement's important, as we spoke about. I think that middle picture over there is about where I put them, sort of in the mid portion of the lesion, one superiorly, one inferiorly. Yeah, it's pretty straightforward once you've done a few. I think it's again, I'm probably adding this to most of my patients these days, with the understanding that it can only help. I don't see a lot of downside.
Those are all great pearls. Dr. Yao, do you have any preference of a single versus a two anchor when you're doing a remplissage?
So I actually like doing two knotless anchors and passing one anchor into the other. I just think it's a very easy way to do it. So I like two anchors.
And Dr. DeBernardis, you like to tie knots through a cannula like Dr. Rikito described, or do you prefer to go into subacromial space, fish out the sutures, and then tie knots?
So neither. I don't tie knots at all. I do similar to Jay. I do a knotless technique. I do two all suture anchors typically. I haven't had too much of an issue with fixation through a separately placed lateral cannula, and convert the repair suture from one into the other and just shimmy it down. So no knots, no need to go in the subacromial space for me.
Okay. So those are great tips and tricks. So I just want to spend a little bit of time before I go to the next talk for indications. And Dr. Yao pointed out, the indications are evolving. I think the most common indication that we see out in practice is an off-track Hill-Sachs lesion, in which the bone loss is subcritical, less than 10 to 15%. Like Dr. Rikito pointed out in his case, high-risk patients are contact athletes. High-risk patients are anybody less than the age of 20 and definitely less than the age of 16, where no matter what you do, non-operative versus operative treatment, in both those cases, the risk of recurrence is pretty high. Remplissage is also finding home in revision cases, like the case that Dr. Rikito presented, a failed Bankart repair, well-done Bankart repair with a subcritical bone loss. And some surgeons are doing it in combination with the Latarjet, especially if a prior bone block procedure has failed. The outcomes are very favorable. There is reduced recurrence compared to arthroscopic Bankart repair alone in the cases that are present in those indications. It has a comparable efficacy in combination with the Bankart repair compared to a Latarjet in revision setting of failed arthroscopic Bankart repair without a critical bone loss. Now, there are certain limitations to this operation. Like Dr. Yao pointed out, there's a risk of loss of external rotation, and there are mixed results. Some authors say that there is not much loss in external rotation, especially abduction, but with the arm at the side, there may be more of finding. Now, if you look at these pictures on the far right, you can see if the remplissage anchors are placed too medially, they are more likely to limit external rotation, and they may be more in the muscular portion of infraspinatus compared to anchors that are placed in the depth of the Hill-Sachs lesion, where they would do a true capsulotenodesis and are less likely to cause too much loss of external rotation. There's always a risk of infraspinatus tear, especially in a young patient who has a traumatic dislocation after the remplissage, and depending upon where the anchors were placed, that can definitely hurt the rotator cuff tendon. So this is that patient 1 year out. He was doing well. He had an MRI, just a nervous guy. And you can see the anchors placed through the depth of the Hill-Sachs lesion and a healed capsulotenodesis in this patient. Again, takeaways, remplissage is a capsulotenodesis of posterior capsule and infraspinatus into the Hill-Sachs lesion. Indications continue to evolve. Off-track lesion with subcritical bone loss is the most common indication. And it shows favorable outcomes with low recurrence rate compared to Bankart repair alone. Well, a low complication rate, but patients should be counseled regarding a potential risk of loss of external rotation. So with this talk, I am going to move on to the next talk in the essence of time. We are running 5 minutes behind. The next talk is on instability with bone loss, diagnosis, and surgical treatment. Now, as pointed out by other speakers, a shoulder has an excellent mobility and flexibility, but it comes at the expense of instability. Shoulder is a joint with a maximum range of motion compared to any other joint in the body, but it is also the most unstable joint. Now, Dr. DeBernard has pointed out why a glenohumeral joint, even though called a ball and socket joint, is different than a true ball and socket hip joint. Now, shoulder is non-constrained. It's a round ball on a flat socket, so-called an articular surface mismatch. The circumference of humeral head is much more than that of the glenoid, and these two factors provide not just rotation on the humeral head, but also result in increased translation, which adds to instability. Three key players in shoulder instability: ligament labrum, rotator cuff, and glenoid and humeral head bone stock, which is what I'm going to focus on for this talk. Now, when we evaluate a patient with glenohumeral instability, whether it's a first-time dislocator or a recurrent instability, we want to know what is the risk of recurrence of instability in these patients. Is surgery necessary to minimize the risk of recurrence? And what kind of surgery will give us the least risk of recurrence in that particular patient? Now, bone loss in shoulder instability comes in all shapes and sizes, unipolar, affecting either the humeral head or the glenoid, or bipolar combined, as shown in these 3D reconstruction images of multiple patients. Now, when we evaluate a patient with recurrent instability in the setting of bone loss, there are certain characteristics in history and physical examination that will point out to this particular phenomenon. Patients with bone loss tend to have a higher frequency of instability events. They have relatively greater degree of apprehension, which results in instability at low angles of abduction. They will complain that their shoulder is coming out with simple tasks like pulling a bed sheet over them. And they will also complain of instability during sleep. When we look at the mechanism, instability with bone loss, especially on the glenoid side, can present with a mid-range instability. If you look at this figure in the bottom panel on the left, it shows you a humeral head on a patient who has 20 to 30% of the glenoid missing. This patient is going to dislocate at 20, 30, 40 degrees of abduction, even without external rotation, with simple tasks like, reaching out for something, trying to put the shirt on, and very common activities of daily living. With bone loss, you can also have an end range instability, especially if the bone loss is largely restricted to the Hill-Sachs side, in which the Hill-Sachs is very medially placed. in which cases the engagement of hill sac with the anterior glenoid rim is what is going to cause instability and can present in higher degrees of abduction and external rotation compared to mid-range instability. As pointed out by Dr. D. Bernardis, imaging plays an important role in determining what is critical or significant bone loss. Plain radiographs can give you an idea that this patient may have bone loss based on the lack of radiodensity below the equator on the anterior glenoid, loss of anterior glenoid rim on a Bernese view. If you are getting that, it's not mandatory. But finally, 3D CT scan is the gold standard for estimating glenoid bone loss, estimating bone loss both on the glenoid side and on the humeral head side. Now, on the glenoid side, the critical bone loss numbers continue to be debatable. Everyone agrees more than 20-25% isolated is critical, but many others believe that lesser degree of bone loss in association with other factors can become critical as well. There's less consensus on the humeral head side. When we start talking about bipolar bone loss, then things change a little bit. And in order to improve our understanding, the concept of glenohumeral contact and glenoid track was introduced. We know that only a part of the humeral head circumference articulates with the glenoid at a given time. And that track on the humeral head is called a glenoid tract, which is basically a contact zone between the humeral head and glenoid in abduction, as shown in the pictures down at the bottom of this slide. Now, it is dynamic. That means it moves from the inferior medial to a superior lateral location, as shown in the last diagram on this slide. And it moves proximally with abduction and external rotation. Now, glenoid tract helps us to understand the interplay between the Hill-Sachs lesion and glenoid bone loss. One thing to remember is that being on track is protective for Hill-Sachs lesion. If you look at this figure on the far left and the bottom panel, you can see this gray shaded area, which is actually the glenoid tract. You can measure this from the width of the glenoid. So glenoid tract roughly corresponds to 83% of the width of the glenoid. Now, if this Hill-Sachs lesion, which is the dotted line, is on this track, it is less likely to engage with routine activities of daily living and abduction and external rotation. But if this Hill-Sachs lesion starts moving off the glenoid tract, it is going to engage and dislocate. But all Hill-Sachs lesion will eventually engage irrespective of their size and location if the original injury mechanism and the provocative shoulder position is created, because the Hill-Sachs lesion was created as a part of instability. Now, risk of engagement increases with the anterior glenoid bone loss because the glenoid tract will become narrow, as shown in this figure. Similarly, if the Hill-Sachs lesion is bigger or more medially placed, as shown in the bottom right, it is likely to become an engaging lesion in routine ranges of motion. Any kind of laxity, whether it comes from a capsular tear like Hagel or if it comes from a pre-existing laxity, can increase the risk of engagement. Now, critical bone loss is a strong independent risk factor for recurrence, not only prior to an arthroscopic surgery, but even after an arthroscopic Bankart repair, which is why a bone block procedure came into vogue. The mechanism is to increase the glenoid arc. By increasing the glenoid arc, we are actually improving the glenoid tract by increasing the width of it and decreasing the risk of engagement. Now, bone block procedure can be the Latarjet procedure, or you could use an autograft like iliac crest or an allograft like fresh osteochondral allograft. Now, Latarjet procedure is probably one of the more popular or commonly performed bone block procedure, which basically involves transfer of the coracoid onto the anterior glenoid neck. And it's known to work with what we call it as a triple blocking effect. It has a bony effect in which basically you're increasing the glenoid arc, a sling effect, which is actually an interplay between the conjoint tendon and the lower half of the subscapularis through which an anterior-inferior buttress is created. And lastly, the ligament or the bumper effect, which is basically the CA ligament reinforcing the anterior capsule. This is a surgical technique. I'm going to try to go through it relatively quickly. So This is an open Latarjet procedure. We do it through a deltopectoral approach. The goal is to expose the conjoint tendon and the coracoid. Here you can see the CA ligament and the conjoint tendon being released. A stump of the CA ligament has been taken, and now the dissection is going to be performed medially in order to do a coracoid osteotomy. I typically take around 2 centimeters of the coracoid, and once the osteotomy is done, preparation of the coracoid graft is performed, and 2 drill holes are made into the coracoid graft. Once the preparation of the coracoid graft is done, we move on to preparing the glenoid for receiving the graft. I do a subscapularis split in which the coracoid is then transferred through the split and fixed with 2 screws. In essence of time, I'm going to skip this forward. I do want to touch upon the indications of Latarjet or any bone block procedure for me. If there is an isolated glenoid bone loss more than 20 to 25%, that patient is getting Latarjet. If there's an off-track lesion with a lower glenoid bone loss, even up to 12, 13%, that patient is getting a Latarjet. And in selected cases, that patient may get an arthroscopic Bankart with remplissage, like the case I showed you before. Revision surgery, if there's a failed prior Bankart repair, he's most likely getting a Latarjet in my hands. Relative contraindications of voluntary dislocation or multidirectional instability. Bone block procedures are less forgiving than arthroscopic surgeries, largely because of neurovascular injury and hardware complications. There is a risk of arthritis, especially if the graft is proud. But bone block procedures have an effective long-term track record. Less than 5% instability is shown in multiple studies. And overall, a bone block procedure, including a Latarjet procedure, is an excellent operation for treating shoulder instability in the setting of bone loss. It has a very low recurrence rate with excellent outcomes, but remember, it is less forgiving compared to an arthroscopic Bankart repair with respect to complications. And critical value of bone loss, bipolar bone loss, and interplay of other factors like shoulder laxity as an indication for Latarjet are areas of ongoing debate. Sorry for rushing through the last part, but we have an exciting case with Dr. Kwan, who's going to take over, and we'll have some time for discussion during that case. Dr. Kwan, all over to you.
All right. Can you put my slides up, please? Oops, you went to the middle. Okay, here we go. Do I have control? I did not have control. Now I have control. Okay, so I don't have any disclosures. This is going to be a case regarding some instability with bone loss. What's happening? Sorry about that. Okay, so this is a 24-year-old male. He actually had bilateral shoulder instability, but I've already taken care of his right side because that was a more dominant side. So he asked me to now take care of the left shoulder. On the left shoulder, he initially dislocated the shoulder about 6 years before he presented to me. And since then, he's seen several orthopedists, some of which actually have recommended surgery, but he declined it at that time. He has participated in some physical therapy, but with minimal improvements. By the time he saw me, he had at least 30 dislocations. Most of them are self-reducible. And he says now he's dislocating with minimal energy, including when he's asleep. Medical history is unremarkable. Surgical history, he actually had an ORIF of the left clavicle about 3 years ago. And unfortunately, he took care of the clavicle fracture, but did not take care of the instability. He tries to work out a little bit, but he's in the financial services. So I think he's a banker. So he only goes to gym every so often, not all that. And he doesn't really participate in any competitive sports. All right, so he's 5'11", relatively thin, reasonable motion, but he has some guarding, especially at the extremes. He does have apprehension for pain and instability, but he has it only at 45 degrees. So even at 45 degrees, he feels a little unstable in the shoulder. Rotator cuff strength is good, and axillary nerve function is also intact as well. And these are his X-rays, and you can see here the plate for the clavicle. Shoulder joint looks okay, right? You don't see a huge bone loss. Now, I will argue, so I actually got this X-ray on his initial presentation to me before I took care of the right shoulder. And since we've taken care of the right shoulder and he's recovered from that, he does admit to having more dislocations. So this is not the most recent x-ray. This is sort of the original x-ray. And subsequently, he had dislocated the shoulder more, I believe at least 2 more times. And then this is the MR that was obtained. And as you could see here, that the glenoid, there's significant bone loss. I think this measured to be about 27% or 28%, depending on who's doing the math. So once again, it certainly will be considered critical. And he also has a fairly large Hill-Sachs here as well. It's not very, it's reasonably shallow, but it is actually fairly large. So what would be the plan at this point? So once again, young, non-dominant arm, reasonably active, but not necessarily in participating sports. It doesn't have to be very active for his job, but he does have multiple dislocations with bone loss on both sides. So the options: would you do this arthroscopically or with open? What would you do with a glenoid? Would you ignore it, lateral J, allograft, some kind of graft? I think the bone loss is fairly significant that I don't think you could really ignore that. So you're probably going to have to do some kind of an open procedure, although I know there's sort of an arthroscopic version of bone restoration that's been going around a little bit. Would you do anything for the Hill-Sachs? If you do it open or knee, what would you do with the Hill-Sachs? And you could also consider doing this as a stage procedure, like arthroscopically go in, take care of maybe the Hill-Sachs with a remplissage, and then later on opening it up. So I need some help. What do you guys think? Dr. Burke, what would you do?
So, Yang, you know my answer, but for this webinar's sake, for this patient you have described as a guy whose first dislocation was at an age less than 20. Age is a very important risk factor for recurrent instability. On top of that, because of recurrent dislocations, this guy has lost bone anteriorly and on the Hill-Sachs side, so it's a bipolar. Even if I ignore the Hill-Sachs, his glenoid bone loss is critical for me. I will go for a bone block procedure in this patient, which will be a lateral J in my hands. Now, so far, I have not had any major issues with Hill-Sachs being a negative player with lateral J. I think once the glenoid bone stock is restored, it doesn't have to be 100%, but the presence of the triple block effect, I think, tends to negate the side effect or the negative effect of the Hill-Sachs lesion. So it'll be a lateral J for me.
Your answer would be to open lateral J, ignore Hill-Sachs.
Correct.
All right. Dr. Rikito, what would you think?
Same. He's bipolar bone loss, but I agree with Dr. Burke. I have not seen for the Hill-Sachs lesion to be much of an issue, but I think it's a consideration as it starts to get a little bit larger as to whether or not you need to fill that defect with bone, not soft tissue, with bone. But again, I haven't seen that in my practice, and I think a lateral J should suffice. Open lateral J.
Okay, Dennis.
To be a little contrarian, I think I would just say that in someone approaching maybe 30%, I would consider distal tibial allograft. I think there are some limits to lateral J. I think it's an appropriate answer here, but I might consider distal tibial allograft to reconstruct that amount of bone loss.
Anything with the Hill-Sachs?
No, I would leave it alone.
Okay. All right, Jay.
Yeah, I agree with Dennis. I'd do a DTA and I'd leave the Hill-Sachs alone if possible.
Okay. All right, so we have the thing. Okay, so this was my plan. I was going to do open capsulorrhaphy. I guess I'm older than most, so I feel comfortable doing an open capsulorrhaphy. So that's what's for the plan. For the glenoid, I generally use just a tricortical off-the-shelf allograft, and I'm going to show you a video here in a second. For the Hill-Sachs, I was going to take a look at it, see what we get. So if it was a deep and very wide, I was actually prepared to put a humeral head allograft in. So we did have one of those available. If not, I thought I was going to either ignore it or do an open remplissage. That is to say, actually just put an anchor in the Hill-Sachs lesion, pass it through the posterior capsule, and just kind of tie it down. So that was sort of the open remplissage. That was sort of the plan. And then I go, see, this is actually the patient. And you can see here that the Hill-Sachs lesion really isn't very big. I mean, I hope you could see it, but you could see the majority of the humeral surface is still maintained. And so for whatever reason, the MRI, I think, overcalled the Hill-Sachs lesion. The Hill-Sachs lesion really wasn't very big. And essentially, I decided to ignore the Hill-Sachs portion of this procedure and basically go directly to the bone grafting. All right, so this is a separate case. I did actually take videos of that case, but the video quality just wasn't very good. So I'm going to show a separate video. It's exactly the same procedure, but just with the anterior bone grafting. So it's deltopectoral interval. I do it in a supine position. It's an axillary incision. Skin flaps, deltopectoral interval. You go into the shoulder joint. And you can see the shoulder joint coming across now. I isolate and release the subscapularis. So I tag out the subscapularis inferiorly, just above the three sisters, so that I don't violate the blood supply. If you go to the inferior portion of the subscapularis, you could actually develop the interval between the capsule and the overlying subscapularis. So this is what I'm doing now. There's capsule underneath. Once I have the subscapularis isolated, I release it. And then I put the retract and retract it away. So all you're seeing now is actually the capsule. Now I'm going to get ready for capsulorrhaphy. So I do a T-capsulorrhaphy. So there's a superior and inferior leaflet of the anterior capsule, and you can see the joint coming across now. I put a tag suture, mainly just kind of isolate all these, and I release it towards the glenoid, and we're going to show that later. And then the inferior leaflet is released all the way to the posterior inferior quadrant of the joint. So that basically you're really doing an inferior capsulorrhaphy here as well. Once that's done, you can see the glenoid bone defect there. And then I take the off-the-shelf tricortical wedge allograft. So yeah, I take this bone. It's everywhere, and it costs fraction of the cost from DTAs or some kind of a fresh frozen allograft. I fashion it, put it into the defect, put it together, and stabilize it with three wires. And these are the same wires that comes into the 3-5 cannulated screws. So once you drill, this is one of the tricks that I've sort of developed, which is I put a suture onto the screw heads. And once it's stable, then I just make sure that the interface between the native glenoid and the allograft is fairly smooth. And once you do that, the sutures are then passed through the capsule and tied down. So basically, I don't want the dead space between the just anterior to the graft, so between the capsule and the graft. So I use these sutures that's on the screw heads to tie the anterior capsule back onto the allograft. And then I just do capsulorrhaphy. So anterior and inferior leaflet of the bone of the capsule is brought out superiorly laterally, tie that down. Same thing with the superior capsule. I do this with number 2 Mercelin sutures. Once that's done, you repair the subscapularis. I know there's concern about subscapularis healing. Of the cases that I've done, I really haven't run into subscapularis not healing. Obviously, these are much younger patients with better healing potential. So subscapular failure, at least clinically, I haven't seen very much. So the wound's closed. This is what it looks like. Generally, postoperatively, for the first 4 weeks, this is true even when I don't use bone graft, which is first 4 weeks, they're kind of resting the arm to the side. They wear the sling if they're outside or around people, but if they're by themselves, I tell them they don't have to actually wear the sling. I just want the muscles to not activate, so the shoulder's resting to the arm is resting to the side. Second 4 weeks, they start moving the shoulder, and then third 4 weeks starts some light resistance training, and after 3 months, they could do some general conditioning and strengthening, possibly even going to the gym, and contact sports is minimum 8 months. Now, I will also say one other thing about that graft. I think all it does is it acts as a scaffolding for the bone to grow in. So if you get the x-rays immediately post-operatively, the graft looks great. It's exactly where you left it. You get the same x-ray somewhere between 2 to 3 months after the surgery, the graft is gone, and you just see the screws that are hanging out there, and it kind of scares you a little bit. And by the time 6 or 8 months rolls around, if you get an X-ray, now you see the bone again. So I think the bone graft essentially just acts as scaffolding for the real bone to kind of grow in a little bit. All right, so discussion points, comments, Andy?
Yeah, I mean, it's a great technique. I mean, I know you've been doing that for a while. I guess one question I had is, are you concerned at all with that piece of bone? It doesn't have any cartilage on it, with causing any scuffing of the humeral head or any issues with arthritis down the road?
Yeah, absolutely. That's always been a concern. So far, I haven't seen that. I know there was a question here on is there an increased incidence of arthritis in these patients? There probably is. We just don't know exactly how much that is. And obviously, if I'm adding just a dead piece of bone on there, is that going to increase the rate further? I don't know. I don't have a good answer for that. And that is certainly a concern. But I'm certainly not sure if this allograft is much worse than something like DTA. In theory, distal tibia does have cartilage, but it's also dead cartilage. So we actually don't even know if that cartilage is alive after a little while. So I'm not sure if that's much of a better option.
Yeah.
So, Dr. Kwan, since I have you on, so what are your indications for open instability repair? Since you're a master on that, I would like you to tell the audience.
Yeah, so I don't know if I'm a master at that, but I generally tend to do open on younger, athletic, dominant arm. So dominant, younger than usually, about age 23 or 25, and usually the dominant arm. And those are the ones that I consider doing open. And obviously, if there's going to be some bony work, I can't do bony work arthroscopically. I know that, like I said, there's some recent techniques that's been trying to be described, but I'm not good enough doing an open technique. I mean, arthroscopic technique for bone loss.
Thank you very much. Our time is up. I want to thank all the speakers for such great presentations. I also want to thank everyone who attended this webinar. If you have any particular questions that you haven't asked, and if you have any of those, you can email us. But again, I want to thank the coordinators, Kathleen, for taking care of the CME. Thank you, everybody. Have a good night.